Good morning and welcome again to our pharmacology online class with me, Sir Joman Baliton, as your lecturer. Our topic is fluid and electrolyte replacement, which can be found in chapter 15 of our main reference. Body fluids. Normal osmolality is 275 to 295 milliosmoles per kilogram. If a client's serum osmolality is 270 milliosmoles per kilogram, his body fluid osmolality is hypoosmolar. To calculate osmolality, use the equation 2 times the serum sodium concentration plus BUN over 3 plus glucose level over 18. Example. Please note of this first example. A client's serum chemistry values are serum sodium level 142 milliequivalent per liter, blood urea nitrogen BUN 15 milligrams per deciliter, and glucose level 90 milligrams per deciliter. His body fluid osmolality is, so let's all compute, 2 times 142 plus 15 over 3 plus 90 over 18 equals 294 milliosmoles per kilogram, or it indicates isoosmolality. Number 2 example. A client's serum chemistry measurements are serum sodium level 146 milliequivalent per liter, BUN 24 milligrams per deciliter, and glucose level 90 milligrams per deciliter. Her serum osmolality is 305 milliosmoles per kilogram. To calculate her osmolality, 2 times 146 plus 24 over 3 plus 90 over 18 equals 305 millosmoles per kilogram. Fluid replacement. Intravenous solutions have a tonicity range of 240 to 340 milliosmoles per liter. Hypotonic is less than 240 milliosmoles per liter. Isotonic 240 to 340 milliosmoles per liter. And hypertonic is greater than 340 milliosmoles per liter. The classifications of IV solutions are crystalloids, colloids, lipids, blood and blood products. To calculate a client's daily fluid needs, fluids for adults may be calculated as 30 ml per kilogram per day. Example, the client weighs 85 kilograms. The daily fluid requirement will be approximately 2,550 ml. How did we arrive with 2,550 ml? Simply 30 times 85 equals 2,550 ml. However, if a client with congestive heart failure is noted to have gained 17 pounds in 2 weeks since the last appointment, the nurse is aware that this represents an approximate fluid retention volume of 7.7 kg. How did we arrive with 7.7 kg? 1 liter of fluid weighs 1 kg. Therefore, a 17-pound gain is equivalent to 7.7 kg. Pulmonary congestion may be noted in a client with overhydration. Pulmonary congestion is a sign of fluid overload. Other symptoms consistent with appropriate hydration or overhydration are weight gain, moist mucous membranes, and urine output of greater than 600 ml per day. Hypotension and weight loss are associated with dehydration and shock. Tachycardia is a compensatory mechanism for hypovolemia or deficient fluid volume. If a client is ordered to receive lactated Ranger's solution, the type of IV solution is crystalloid solution. D5 water is isotonic, but when the dextrose is metabolized in the human body, it becomes hypotonic. For instance, a client received 3 liters of D5 water. With continuous use of 5% dextrose in water, the intravenous fluids become hypotonic. If a client in severe shock is ordered to receive dextran as a volume expander, this type of fluid is known as colloid. Dextran is a colloid. Normal serum potassium level is 3.5 to 5.3 milliequivalent per liter. If a client with a history of vomiting presents to the emergency department with a serum potassium level of 3 milliequivalent per liter, the client's serum potassium level indicates hypokalemia. Another example, a post-operative client enters the post-anesthesia care unit and blood studies are done. The client's serum potassium level is 2.9 milliequivalent. The nurse should monitor ECG readings. Why? This level of potassium puts the client at risk for cardiac dysrhythmias. The nurse must monitor for cardiac irregularities. In monitoring a client taking potassium supplements, the nurse observes for signs and symptoms of hyperkalemia, which include oliguria, tachycardia, and later bradycardia. Intravenous potassium chloride should never be directly injected, but must be diluted so that it will not cause venous or tissue damage or more serious effects of a large bolus such as cardiac standstill. Check for infiltration because potassium is irritating to subcutaneous tissues. Check for phlebitis because potassium is irritating to the veins. Check for adequate urinary output. That is, kidney dysfunction can cause potassium retention that may lead to hyperkalemia. If a client is ordered to receive potassium chloride or KCl tablets, the nurse should instruct the client to take potassium chloride with 4 ounces or more of fluid or at mealtime. Potassium chloride should be well diluted to avoid gastric upset and improve absorption. A drug group that can cause hypokalemia is potassium-wasting diuretics. These drugs cause the body to lose potassium. A client is taught to take his potassium because a medication he is receiving can cause hypokalemia. If a client's serum potassium level is 5.4 milliequivalent per liter, an intervention that may correct this type of potassium imbalance is restriction of foods containing potassium. Mild hyperkalemia may be treated with dietary restriction of potassium-rich foods. If a client's serum potassium level is 6.9 milliequivalent per liter, an effective method to correct this severe hypokalemia would be to administer sodium polystyrene sulfonate, or K-xalate, and sorbitol. 6.9 milliequivalent per liter is considered severe hyperkalemia and requires aggressive treatment with K-xalate and sorbitol. This increases the body's excretion of potassium. Calcium. The appropriate range for serum calcium is 4.5 to 5.5 milliequivalent per liter. If a client's serum calcium level is 3.7 milliequivalent per liter, the nurse correctly interprets that this level is low. A nurse is teaching a client about ways to avoid hypocalcemia. Dietary recommendations indicate that the vitamin that is necessary for calcium absorption is vitamin D. Vitamin D enhances the absorption of calcium in the body. Tetany symptoms results from severe calcium deficits. The nurse checks for symptoms of tetany. The following is associated with tetany: twitching of the mouth and numbness of the fingers, carpopedal spasms, and laryngeal spasms. If a client is receiving D5 NSS via a peripheral IV, the client is prescribed to receive calcium gluconate. The nurse knows that calcium should not be mixed with saline solution. The appropriate response for the nurse is to ask the healthcare provider about changing the IV solution to 5% dextrose in water, or D5 water, because saline encourages calcium loss. This is the correct action to take when administering IV calcium. The group of drugs that contain magnesium and, if taken in excess, can cause hypermagnesemia includes laxatives and antacids. Laxatives and antacids may contain magnesium and have the potential for misuse in clients. That ends our topic discussion. Let's proceed to practice question number 1. Your client has a calcium deficit. Your assessment includes signs and symptoms of tetany, including all of the following except twitching of the mouth, tingling and numbness of fingers, urinary retention, carpopedal spasms. The answer is C. Practice question number 2. You advise ER to eat foods rich in potassium, including all of the following, except A. Dry foods, B. Bananas and prunes, C. Broccoli and peanut butter, D. Eggs and whole grain breads. The answer is D.